So keep us on schedule here. So good afternoon again. Thank you for joining us for today's webinar, Methadone 101, What Community Professionals Need to Know. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. My name is Katrina Hernandez, and I'm an engagement specialist with OPEN. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based resources and services. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD trainings for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machines and distribution boxes, and we offer naloxone administration training. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, and others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies.
Okay, yeah, thank you so much for introducing us, Katrina. I'm Liza Hutchinson. I may know some of you. I am one of the clinical consultants with OPEN, and I'm a family physician and addiction medicine physician, and it is my deep honor and pleasure to introduce Tom Hutch today. Tom and I were co-chief residents back in Seattle, and I've promised to stick to the script of his bio instead of introducing him with my own bio and all of my own commentary. So I'm going to read that to you all. So Tom is the medical director of We Care Daily Clinics, which is an organization of opioid treatment programs serving the Washington communities of Seattle, Auburn, and Tacoma. He completed his medical training in family medicine at Swedish Medical Center First Hill in Seattle, where he then taught residents as a faculty physician before working to address systemic causes of behavioral health disorders and addiction in community health centers and as a county jail physician in King County. Dr. Hutch is a clinical assistant professor at the University of Washington Department of Family Medicine and provides instruction to addiction medicine fellows. He also worked with the Washington Healthcare Authority to expand hepatitis C treatment access, has a research interest in improving cervical cancer screening within underscreened populations, and serves as a medical director of Indigenous Pact, which assists Native American tribes in establishing clinics to address substance use disorders. And I will also just say that to me, Tom is my encyclopedia. He is my go-to with any clinical question about substance use disorders or any regulation out there under the sun, and is a profoundly dedicated innovator in SUD care in a way that honors evidence, regulations, and most importantly, patient experience and patient needs. And he makes a really mean homemade bagel. So it is my great honor to introduce Tom. Take it away.
This is Methadone 101, what community professionals need to know. And there's a lot in here. And that means that I think we all need to know quite a bit about it. Liza gave me a wonderful intro, so I'll skip this, except to say that I don't have anything interesting to disclose. And you'll see my email on here. I want you to email me. There's a lot to talk about. It's impossible to get through everything, despite trying. And if we don't get to your question, I want you to email me and we'll figure it out together if I don't know it. These are some of the learning objectives. I'm not going to read them all, but I will say that you don't have to be ordering methadone for this to be important to you. It's our responsibility to help people navigate the system and to do some options counseling to know how to do that well. My goal is to elevate the knowledge that this wonderful multidisciplinary group already has and help us all advocate for access. If we want to understand how to help our patients, we have to understand the system in which they operate. And as you'll see, the way that methadone is delivered in the US is unlike any structure of any other medical or behavioral health delivery system, and our patients need our help in improving it. So here's a roadmap of where you can expect we'll go today, and I'm going to be sure to leave some time for questions and discussion before we get to Canada. So you're all here because you already know this is critical. You know all this, and I'm not trying to convince you. We're not trying to convince each other, but we're trying to learn how to be well-versed in explaining this epidemic to any member of the public in a way that does justice to the immensity of the problem. So we should challenge ourselves to be able to be familiar with this, so much so that we're able to describe it to somebody else. So while the data shows a 4% decrease in 2023 to about 105,000 total overdose deaths in the US, the long-term trend demonstrates clearly, as we all know and are horrified by, a sustained increase in overdoses, and synthetic opioids, specifically illicit fentanyl, is the primary driver of this, accounting for more than 72,000 overdose fatalities in 2023. That's more than Americans died in Vietnam every single year. Drug overdose is the leading cause of death for Americans 18 to 44. The epidemic of opioids costs the US over $1.5 trillion a year, and that's accounting for lost productivity. I know I myself don't get up to work every morning necessarily thinking about decreasing expenditures, but decreasing hospital visits and hospitalizations associated with opioid use disorder because we have better access to care would allow us to allocate those healthcare dollars elsewhere. And this client population and treatment community faces a lot of stigma. And sometimes we need to advocate for medication access, and our audience isn't really as up to date with regard as to the evidence and cost effectiveness as we'd hope. So being able to speak in terms of cost savings, returned function, increased productivity is important in our ability to advocate for people. In Michigan, there was a 5.7% decrease in overdose deaths, outpacing the national average in 2023, and accidental overdoses account for roughly 1 in 5 of all deaths in that 18 to 44 age bracket. So you'll see this little beautiful coastline heavy Michigan icon throughout the talk. I was able to speak with inpatient providers, pharmacists, even people in government in Michigan to prepare for this talk. I know I'm not from there, but I did what I could, and hopefully you find it Michigan specific enough to be helpful. Despite recent overall improvement, both Black and Indigenous populations in Michigan continue to experience overdose mortality rates more than double those of white residents. So 1 in 4 people who needed substance use treatment in 2023 received any, and about 1 in 5 people who needed opioid use order treatment received any. So I'm going to spend time on access and how many people are actually getting the care they need, because a lot of what we're going to talk about today has to do with how we as a nation and in the treatment community have not done a good job the last 50 years making this highly effective treatment as readily available as possible, especially to a population that has trouble accessing services. So as you'll see, MOUD, medication for opioid use disorder, is the undisputed gold standard of care, and it reduces mortality. And I invite you during this talk to consider any other terminal chronic disease in modern medicine where the most effective mortality-reducing intervention is systemically and routinely withheld from a significant portion of the population due to structural barriers and provider hesitancy. Furthermore, access is unevenly distributed. Data show pronounced disparities that disproportionately limit access for minority populations, women, and people in rural communities too. Throughout the talk, I have also integrated some audience questions. Thank you for those of you who were thoughtful in providing some questions when you signed up for this talk. All of those questions have been integrated into the talk with my best shot at an answer. And thanks too for your participation throughout. I would love to answer any questions. Please type them in. I'll get to them in the end. And if I don't, please email me. So is there methadone in the UP? Yes, technically, there's methadone in the UP. There is one OTP, opioid treatment program, methadone clinic, up in St. Ignace near the Mackinac Bridge. The rest are in the Mitten. And yes, I've been working on my Michigan lingo. I'm from Ohio, so I'm not starting at zero. But that is where we're at. There's 53 OTPs or methadone clinics, places you can get methadone in the outpatient world in Michigan, treating about 10,000 clients. Here's another real audience question or two. How does methadone compare to other medications and substances in terms of addiction and recovery? What's the difference between methadone and Suboxone? A question that we should all be really well versed in when we're asked. Well, what do we mean when we say medication for opioid use disorder? There's all kinds of medicines you might use in the hospital to treat symptoms, but there are three only that are approved by the FDA for actually treating opioid use disorder. One is methadone. It comes in a pill form, but most commonly, especially in the outpatient world, a liquid. Buprenorphine is another medication that is a partial agonist, and we'll talk about what that means. You'll hear this when you hear Suboxone and Subutex. Those are brand names of the type of buprenorphine that you put under your tongue, and Sublocade and Brixadi, and those are brand names of shots that you can take that last between a week and a month. And there's naltrexone as well, which is an opioid blocker. So how do these work? Methadone and buprenorphine are opioids. People take them for opioid use disorder because they're dependent on opioids, usually heroin or fentanyl. When they try to stop heroin or fentanyl, they get very sick and they have to continue using despite the risk that comes with use every time, including possibly overdosing and dying. Methadone and bup or buprenorphine are safe and effective pharmaceutical opioids that people can take to reduce the risk of death and prevent them from getting sick. They don't cure opioid use disorder. But as anyone in recovery from anything will tell you, there is no cure. Every day is a battle. But these medications stop people from dying and they return function so that they can have the space to do the work of recovery and get their lives back. We've got opioid receptors in our brains, and the opioids fit into them like a key into a lock. Methadone fully activates the opioid receptor in the brain. When it's activated, that receptor sends signals, and people get opioid effects. At the right dose, methadone and buprenorphine don't cause people to feel like they're taking opioids. They take people who would otherwise be in withdrawal, and they restore them back up to the normal functioning baseline. I have plenty of patients who have lived normal lives and are fully functional who take medication for opioid use disorder. Buprenorphine, similar, fits into that same receptor like a key and activates it. However, you can think of it like a partial activation, and we'll see more on that in the next slide. Naltrexone is an opioid antagonist or blocker, and you can think of it as sitting on the receptor and blocking other opioids from having an effect, including opioids people might take, like fentanyl or heroin. So some people find a lot of success when they take naltrexone, but it's very hard to start because most people getting into the treatment are still taking heroin or fentanyl, and you can't take naltrexone, you can't start it while you're still using heroin or fentanyl. It's very hard to stop heroin and fentanyl for a long enough time, maybe 7 days or longer, before it's safe to start naltrexone. Methadone and buprenorphine also help a little better with cravings once people are stable, and they help better with a lot of outcomes, including retention and treatment. Um, but again, naltrexone certainly has a role. So methadone here in green is a full agonist. The more you take, the more you'll feel it. People with very high tolerances to fentanyl do very well on methadone. They just need higher doses. Buprenorphine has a ceiling. When you take a small amount, it helps, and a larger amount helps more than that. But at some point around 32 milligrams, taking more doesn't have an additional effect. The upside to this is that it's inherently a pretty safe medication with a low risk of overdose, but the limitation on its effect has become a problem in the era of fentanyl because fentanyl is very potent. And people who have really high opioid tolerances from fentanyl find that buprenorphine is not strong enough to control their cravings. There are dozens of studies on methadone. There are decades of data. It works very well. People receiving methadone for opioid use disorder are less likely to die from anything, all-cause mortality. They're also specifically less likely to die of an overdose. 59, some studies generally 50 to 59% less likely to die of an overdose if you are taking methadone. It also reduces the risk of other important things like going to jail or getting HIV. For a patient with a history of a heart attack or a stroke, starting a statin reduces the relative risk of all-cause mortality by about 20%. Retaining somebody with opioid use disorder in methadone treatment reduces their relative risk of all-cause mortality by over 50%. Methadone is one of the most effective meds we have for anything. And that's the outcome of life and death. Methadone is, of course, even more effective at helping people just get their life back on track, use fewer drugs, get a job, reconnect with their families, with their communities. Data shows that people data shows that it helps people do those things in about 1 in 2 people who start methadone. And as a primary care doctor, I can say it's an incredible privilege to be able to use a medication with numbers that good for such impactful outcomes to patients, families, and society. People get better, and we need to do a better job getting it to people, as we'll see. It's harder to get started on buprenorphine in the fentanyl era. We used to have people stop heroin for 8 to 12 hours, start taking buprenorphine, and they would do really well. But fentanyl sticks around in the body for a long time, and it causes a high opioid tolerance, and that leads to a lot of problems getting started. And one of these is called buprenorphine precipitated opioid withdrawal. So fentanyl is a really strong agonist or activator, and the brain gets used to a certain amount. Buprenorphine is a weaker opioid, but you can think of it's the bully at the receptors. You can think of it as being more magnetic to the receptors. So it has a higher receptor affinity, we say, and it kicks off the fentanyl. This sensation of all that fentanyl being kicked off and replaced with a weaker opioid results in an abrupt and terrible sickness that unfortunately for a lot of people they need fentanyl to treat that sickness that it causes, and then they have a huge amount of apprehension in trying to use buprenorphine again in the future. This type of precipitated withdrawal doesn't happen with methadone. It's safe and it's easy to start in people who need it. Here's another audience question. Is methadone safe during pregnancy? Great question. As demonstrated in research like the MOTHER study, both medicines are safe and effective. That's the standard of care in pregnancy. While buprenorphine might yield in some studies less severe neonatal opioid withdrawal syndrome, which is something you'll get from taking any opioid throughout pregnancy, methadone is a safe and effective treatment with great maternal retention rates, some studies showing higher retention rates. The risk of precipitating withdrawal when starting buprenorphine is especially important to try and avoid during pregnancy too, because of the additional risks of preterm labor and other complications that come with acute illness. So you can only get methadone for opioid use disorder in the US at a methadone clinic or an OTP. We call ourselves OTPs because we do more than just methadone. We utilize a lot of buprenorphine and naltrexone here, and we treat conditions adjacent to addiction like hepatitis C. So you'll hear me saying OTP. There's more than 2,000 OTPs in the US, and they're providing care to at least 300,000 patients. It's a highly regulated environment, as you all probably know. There's a lot of mystery around it. A quarter of people in the US have no OTP in their home county. Rules require that people attend frequently. Regular toxicology testing is required federally. Why? Why can't we prescribe methadone for opioid use disorder? Why does the federal government find it necessary to so strictly regulate this type of treatment compared to other types? Why are there so few clinics compared to how many people need treatment? These federal regulations are an anomaly within modern medicine. And for example, the federal government doesn't dictate to an oncologist how often they have to order specific lab work. So, how did it get to be this way? I'm glad you asked. Understanding history is very important. And I promise you'll feel more confident with the way things uh, are and why they're the way they are so that we can kind of build on that the rest of the talk. I'll limit this to 5 minutes, which is the same amount of time it takes for me to do the paperwork to plead to SAMHSA to allow my patients to continue methadone when they go to inpatient treatment. It's 1914. There's this Harrison Narcotic Tax Act. Physicians have to register and pay a tax to prescribe opiates. Fine. The act was utilized, though, aggressively by federal law enforcement to prosecute physicians who attempted to prescribe maintenance opioids for dependent patients, people addicted to opium, Civil War vets addicted to morphine. In 1919, the Supreme Court ruled that prescribing opioids to maintain a patient's customary use was not considered legitimate medical practice. Remember this distinction and this word specifically, prescribe. Not allowed to prescribe opiates to treat opioid use disorder. This is really important in understanding the way that methadone is delivered currently. So this decision provided the legal mechanism to prosecute physicians and force the closure of early addiction clinics. And yes, we did have those. We had morphine clinics in the 1920s. Consequently, for the next several decades, addiction was managed primarily as a criminal justice issue. By 64, the approach to opioid addiction began to shift back to the medical domain due to the work of these three researchers, Doctors Dole, Neiswander, and Creek. Dole and Neiswander approached addiction like a metabolic disorder requiring physiologic stabilization. In fact, Dr. Dole was a pretty famous diabetes researcher. Methadone's been around for a long time. It was developed in Germany for pain treatment during World War II. The opium supply was actually cut off to Germany in World War II, and they had to figure out a synthetic solution. Methadone is not great for pain, but they did find that it lasts a long time. So Dr. Creek here was someone who showed that methadone had a sufficiently long half-life of about a day. So their 65 publication provided clinical evidence that people stabilized on this med could stop illicit opioid use and return to normal occupational and social functioning. But like many new therapies, especially those that are narcotics and help people with a stigmatized disease, methadone faced a really rocky rollout in the 60s. Despite clinical evidence, it was not integrated into routine medical care. It was seen as an investigative drug. Pushback came from traditional recovery groups like 12-step models who prohibited their members from taking medication. Communities of color saw it as a form of government mind control. The FDA, who resisted its approval and publicly doubted its effectiveness. Public concern over clinic profit motives and cash-only clinics, which existed too. Strong messaging from policies from the federal government, including the first chief of the Federal Bureau of Narcotics, Harry Anslinger. His philosophy essentially included locking people up for drug use and set much of the framework for the war on drugs and the war on people that has contributed to the US today, holding 20% of the world's incarcerated population. So the rocky rollout led to this correction or this response, a strong federal response. In 1971, the Nixon administration launched the war on drugs. On the right in this photo is Jerome Jaffe. He's the drug czar, and he was an early proponent of methadone for opioid use disorder. But not everybody was so progressive in the administration. John Ehrlichman, Nixon's domestic policy chief, later stated on the record, and if you haven't read this Harper's Magazine article, it's fascinating, that the administration deliberately associated heroin with Black populations to justify aggressive policing and disrupt those communities. So consequently, the Narcotic Addict Treatment Act in 74 established a very segregated system for methadone. The feds sort of responded to all of these concerns I said in the last slide. Instead of being prescribed like another medicine for any medical condition, as we'll see in 21 CFR, methadone for opioid use disorder was relegated to standalone clinics governed by a different code of federal regulations, 42. More on that soon. But the regulatory isolation combined with restrictive local zoning laws resulted in clinics being disproportionately placed in urban minority neighborhoods, and that established a structural stigma that separated patients and medicine from the rest of the system. In the year 2000, the Drug Addiction Treatment Act allowed physicians to prescribe buprenorphine from standard medical offices. Well, why was a law needed for providers to be able to prescribe an FDA-approved medication. Because remember, at baseline, it was still not legal, even in the year 2000, to prescribe an opioid medicine for the purposes of treating opioid use disorder. So a two-tiered system emerged. Buprenorphine became part of mainstream outpatient medicine. Methadone remained structurally isolated in clinics governed by 42 CFR. And you see that still today, the structural division directly correlates with the demographic disparities that we see in treatment today and in maps like this. Methadone remains the primary treatment modality for a lot of Medicaid enrolled populations in urban settings. And because opening an OCP is so administratively and politically difficult, large geographic treatment gaps exist. So history's over. But I think that will have really helped. So, for instance, what did I mean when I said methadone was sequestered in 1974? Today, methadone treatment for OUD remains structurally isolated from mainstream medicine. It's governed separately under 42 CFR Part 8, as you see on the right here. So, the framework for governing life-saving addiction medicine is so divorced from mainstream public medical practice that it's categorized next to the federal detention of primates. So, review or quick quiz. Can methadone be prescribed for opioid use disorder? No, it can't. Only buprenorphine can. Okay, well, I know someone whose provider's been prescribing them methadone for years. So, how is that possible? Well, it can be prescribed methadone for pain. So, in that context, it lives over here on the left with 99% of the way that people are treated in this country within 21 CFR. It's not about the methadone. It's only when people have opioid use disorder that they're relegated to this separate structure. And how do I not get in trouble for providing methadone to people who have opioid use disorder? Well, the law is that I can't prescribe opioids for opioid use disorder. So I don't do so with a prescription that I send to the pharmacy. I do so with an order that is dispensed within the same building from a stock bottle of methadone that we buy. So this is the same reason that hospitals are allowed to utilize methadone for opioid use disorder. And that now you know that's why OTPs exist the way they do. In order to be able to get around the rule of not prescribing methadone for opioid use disorder, we're dispensing it. So these rules have been in place for decades. Yes, this is an actual photo of the papyrus on which they were penned. All but one of these, by the way, has changed, and we'll talk through them. But as you can see, this and many federal regulations are what the industry has been dealing with for 50 years. So in addition to federal, there are state regulations too. State authorities frequently implement their own administrative rules that extend above and beyond the federal baseline. In Indiana, for instance, there's a statutory cap on OTPs. In West Virginia, there's a statutory moratorium on the licensure of any new OTP. And there hasn't been a new one there in West Virginia for almost 20 years. There's a current lawsuit there actually about it right now. So businesses like liquor stores and gas stations undergo local administrative hearings to open, but establishing an OTP in these states requires an act of legislature. This is what we mean when you hear someone say that patients with OUD and those who help them still face structural stigma. So I want to integrate some patient voice here. These are quotes to me from my patients in 2020. And there's this terrible irony in requesting that some of the least stable and most vulnerable patients in our society come to the clinic with great regularity every single morning under threat of being discharged from treatment. So what happens when an immovable object like the scroll of papyrus and its take-home schedule requiring people to come to the clinic every day meets an unstoppable force like the worldwide push to stay home? Most states during COVID, including Michigan, issued guidelines permitting a radical increase in the quantity of permissible take-home medication. That's medication given to them in individualized bottles for their use on future days, rather than having to come into the clinic every day. So here you see that they say, in the example of somebody who's getting one take home a week, which is pretty much everyone, it's very standard to get at least one a week on a Sunday if your clinic is closed, may now receive between 7 and 28 days of medication. Radical change. What happened? Well, it went great. People who received more take-homes were more likely to remain in treatment. Diversion reports were pretty rare, and methadone-involved overdoses for OTP patients at the population level, mostly in studies of emergency room visits, remained stable. Ideally, this will help, we think, with retention and treatment and attracting patients to treatment who wouldn't otherwise be interested. Going back to some patient voice, there's thankfully some good articles about what patients have to say about this, and you can see here this person feels more like a normal person, and that is what we're all after when we're helping people get into recovery. So thankfully, this data and the changes in patient experience were taken seriously, and permanent changes were made in February 2024 to the final rule that governs the treatment of opioid use disorder, 42 CFR. So let's go over some of the changes that you need to know about so that you can do an effective job counseling patients and what to expect in treatment these days, or advocate for better care in systems that aren't quite up to speed. It used to be required that clients and clinics prove that somebody has been addicted to opioids for at least a year before you could offer methadone. So now that's removed. People under 18 used to have to fail 2 detox attempts uh, at treatment, so a detox only treatment, and then you could start methadone, and that's been removed too. As Michigan doesn't have an additional age of consent requirement, there is technically no minimum age for treatment in Michigan. We're seeing people develop severe opioid use disorder after just less than a year of fentanyl use, so this has been a really helpful change. In Michigan, technically, this is still on the books, requiring a year or more of opioid use disorder. But if you like to go into the draft websites and take a look at draft rule language, I will point out that in January of this year, this draft rule was proposed with that taken out. So it's probably safe to say, especially very soon, that that rule is not needed in Michigan. It's also the kind of thing that you can submit an exception request for online. So, another good audience question. Is it appropriate to begin methadone inpatient and connect with the clinic after discharge? I believe regulations prevent us from doing this. My hospital policy doesn't allow it. Do you see this capability in the future? It's the future. Now's the future. Yes, this should be offered, and we do this at our clinic. Michigan state regulations don't prohibit admitting a hospitalized patient to an OTP via telehealth, neither do federal, and we'll look at how federal regulations allow it. So let's do a quick case. This is a 59-year-old woman who's hospitalized for pneumonia and cellulitis, requiring 2 surgeries. She uses fentanyl. She hasn't gone a week without fentanyl use for years. During this time in the hospital, instead of letting her get sick and leave, they started methadone, which is very important for preventing discharge and absolutely within the rights and laws and ethical duties of care teams inside of hospitals. So she's stabilized. She's taking 120 milligrams of methadone over the course of most of her stabilization, and she's going to discharge, but she's going to discharge to a skilled nursing facility, and one of them accepts her. Can she continue to receive methadone at the skilled nursing facility? Well, we need to find a way for her to be able to. The skilled nursing facility can technically dispense it, and we'll talk about that later, but almost none do. So she should get it from an OTP. But to get methadone from an OTP, she needs to be admitted to one. She isn't. She was started on methadone in the hospital. So what do we do? At what point in this whole transfer from the hospital to the SNF does she go to an OTP? Well, you could try to put her in a car and swing by an OTP on the way to the skilled nursing facility and cross your fingers and hope that all the timing works out. But a better way to do it, and the way that we do it here, is that 42 CFR allows for this. They allow for you to essentially do a telehealth visit and call from the OTP and have the provider just do an admission remotely while the person is sitting in the hospital. There's 2 reasons that this is allowed. So the first, and this is even before 2024, allows for some other provider to do the physical exam portion of the admission note that an OTP does. And in 2024, further, it was allowed that if you are an OTP doing telehealth admissions, you can now do your physical exam essentially over telehealth as long as you have video and it's medically appropriate to forego an in-person physical exam. So at our clinic, we have a Teams chat with some local hospitals where they could give us a call. They do an online registration of of the patient, and we just connect with them for a virtual visit and complete admission so that they're ready to go and receive medication from us as soon as they leave the hospital. So that's a big change that OTPs have the option of starting people, and I think that there's a lot of potential there. So similar case, but different discharge situation here. This is a 26-year-old who is hospitalized for fractures and wound care and hasn't gone a week without fentanyl use for years. And over 11 days in the hospital, he started on methadone. He's nearing stability. He's going to be discharged on a Saturday. This story might start sounding familiar to you. And the local OTP makes him an appointment for intake on Monday, and he says, I think I can go. I hope I can. I don't know how I'm going to get there. Don't have a car and I don't know where I'm staying, but Monday sounds good, I guess. Can we send him out on Saturday with some methadone so that we don't incur the huge cost of continuing to hospitalize him just to give this person methadone for another two or 3 days? Yes, we can. 21 CFR has a rule called the 72-hour rule that we'll talk about a bit. We can um, take somebody who is in withdrawal and needs to take it just says narcotic, but we're usually talking about methadone, up to 3 days of methadone to relieve withdrawal while you're making arrangements for treatment. As of August in 2023, you can actually give all 3 of those days of methadone to the person at one time. So this allows for coordination of care, providing medication for 3 days of hospital discharge, for instance. It allows all kinds of other possibilities too. There's a clinic here in Seattle in which you can start methadone and they give you 3 days of methadone while they contact another OTP to do your full intake. This can be done in emergency departments to facilitate admission there. And a group I'm involved with, that's the fourth resource here on the slide, Scala Northwest, has some resources online for how to do that, but also how to get the medication to them after they leave the emergency room. So there are some barriers to this because let's skip ahead to this slide and actually read. I'm not going to read this entire thing, but it says here a practitioner may dispense narcotic drugs, we'll say that's methadone, to one person for one person's use for 3 days. So why don't hospitals do this more? There are a few in my area that do this, and it's, of course, very helpful with decreasing bounce back rates for people presenting to the emergency room after discharge. It decreases length of stay in the hospital. Of course, it increases patient satisfaction. I don't think anywhere in Michigan is doing this in the phone calls that I've made. So why not? And I'll just say that when you're talking with your hospital pharmacy departments, and I speak with many around here, these are the issues that are raised most, and they're legitimate. So you have to be sure that your inpatient MAR in your electronic health record is clearly showing that, this wasn't necessarily given inpatient, but it's not an outpatient prescription. That's kind of tricky to do. As you saw in the laws language, it also says a practitioner can dispense it. So do you really have to go upstairs and grab the hospitalist and walk down to the lobby and hand the medication to them, or can it come from a pharmacist? What about a nurse? Locking containers. Do you have to put the methadone in a bottle for them and then put it in a locking container? Of course, concerns about diversion and misuse, although those are essentially the same decisions that we have to make every day in the OTPs here. So there's good news and bad news about this. The bad news, essentially, as you're finding out, is that this wasn't written very well. In addition to the practitioner dispensing and the questions about whether that can be a nurse or a pharmacist, they also say that medication can be dispensed while arrangements are being made for treatment elsewhere, but then they later say that the medicine is for the purpose of initiating maintenance treatment. Well, what if the initiation's over, right? In our example, it happened, you know, 11 days ago, and now we're talking about continuing the medication through the weekend. So our own state meets with the DEA monthly about this, and it's difficult for states or SAMHSA to provide guidance because the DEA doesn't want other agencies interpreting their rules for them. As you might guess, the DEA does not love putting interpretations into writing. The good news is that there's a lot of published work of hospitals and emergency departments who utilize this rule this way. And it's a couple of those works are cited here. Sometimes the DEA will respond in writing if they're asked a specific enough question. I've had success stating exactly what I want to do and asking them if they have a problem with the plan in an email. I'd recommend that anybody who wants to work on this, look up your local DEA diversion office, which you can do online with this tool, and just call. They are not the scary guys with the guns and the coats. These are diversion officers. In our case, in our area, one of them used to work for a state agency, another was a counselor. These are generally people that also care about patient access. And I know I can only speak from my local area, but you might as well just go to the source. If you're worried about how the DEA is going to think, then just get on the phone with the people that are eventually going to, look into it and tell them your plan. So lots of different types of facilities can technically start or continue methadone, like jails, skilled nursing facilities, as long as they have a clinic or hospital type DEA license. It's not common, but it's possible. And that was a big change. The rule change also clarified that medication continuity at OTPs shouldn't be contingent on counseling. I acknowledge this is framed as a good thing, but I also want to say counseling is important. I think there's a sort of a false dichotomy in treatment of medication or counseling. And the thing to celebrate here is that there's fewer barriers, and fewer barriers means requirements are not forcing you to make a care plan that isn't the best for you and your patient. But I think that clinicians should have the freedom to make a care plan that's best for a client's situation. We used to be limited to 30 milligrams as the first dose of medication. Speaking of unprecedented government overreach into medical practice that doesn't exist elsewhere, now we can start people on higher amounts, which is good because fentanyl is increasing everybody's tolerance. Take-home medication is methadone or bupe that we can hand to people and they take on future days. Two things are considered: the amount of time that someone's been in treatment and a group of 6 qualitative criteria about how they're doing that we'll go over soon. So time in treatment has always been a huge barrier. As you can see here, people needed to be doing well in treatment for 91 days just to get an additional day per week. So that timeline was really discouraging to people starting treatment, and the new regulations essentially take this away completely. You can have a week of treatment, the first day you show up. That's not necessarily done because you also have to think about whether it's a good idea and how someone's doing. And those are what we call the 6-point take-home criteria, which are these. So this is a set of qualitative measures that we have to assess how people are doing. And these have improved greatly with the rule changes too. So rule changes, number one, they used to say that absence of recent abuse of drugs, in their words, was required in order to provide take-homes. Most clinics interpreted that solely as the result of toxicology testing. The wording now states that someone should have an absence of active substance use disorders that increase harm. So that shifts the focus onto the impact that substance use is having on people and those around them, and that's a better indicator of safety. Take-home medication could be limited by regularity of attendance, which some clinics interpreted as counseling attendance. So now it's clarified that they just mean medication attendance. Absence of recent criminal activity has been updated to absence of recent diversion activity, which is great. People, I guess, won't lose their take-homes for tax evasion. The wording stability of the patient's home environment and social relationships used to complicate things for people who were unhoused, but could otherwise keep their medicine safe. And so this has been changed as well to focus on whether the medicine can be kept safe. What hasn't changed is that methadone still has to be dispensed and not prescribed, and it requires non-OTP practitioners and facilities to stock methadone. And there's also a rule that we have to do 8 toxicology tests every day. Here's another question. What does a typical methadone dosing process look like at a clinic? Well, at our clinic, you walk in the door and type your number into this kiosk, and it tells you your first thing that day. Most of the time, you just have to get medication. But if you have a counseling appointment or something, it'll say your counselor will be right out. And so if you just need to go get medication, you are pointed to one of 9 dosing windows. Here we see Georgiana, and we'll walk in and say hi to Georgiana. She'll ask us some identifying information. She'll use the EHR to use this pump to measure out the exact amount of methadone somebody needs, either into a cup to take just now or into take-home bottles, which you see there on the right. And she'll label each one, and you'll be on your way. If you're coming just to dose, then it takes less than 2 minutes on average for us. But that's the general idea there. I want to just advocate for the scope of care because people don't often want to go anywhere else besides their OTP. In our case, anyway, they've faced a lot of stigma across the medical landscape, but they're way behind in things like cancer screening, and we see people so often, so it provides a lot of opportunities. While people anyone who's paying attention, I think, should be critical of federal regulations. But OTPs themselves can serve a really important purpose in a community. They're often places that people can access care from providers and counselors and peers that they trust. Here's another actual audience question. What are reasons to refer someone to methadone? So easy case here. This is a 28-year-old smoking 2 grams of fentanyl a day. They've had a history of multiple tries of buprenorphine. They have persistent withdrawal symptoms and continued fentanyl use when they're on buprenorphine or Suboxone. And they have a really high opioid tolerance, and it would probably be hard to start buprenorphine. So great candidate for methadone here. What about somebody who's 34, they're eating or drinking or otherwise taking 15 grams of Kratom powder daily for some back pain? They have a really high cost. They're spending a ton of money now on Kratom, and they do find that they have some withdrawal, really difficult time stopping, but they want to stop. They don't have a history of heroin or fentanyl use. So this is a person with lower baseline receptor tolerance compared to the other opioids we talk about. Because I know it's a big deal in Michigan, we're going to spend 2 slides on Kratom. So Kratom is a big deal in a lot of states. It does act on opioid receptors, so you can think of it like an atypical opioid. It does cause tolerance and withdrawal. And because it's legally accessible and not detected on a lot of drug tests, Kratom or 7-OH. 7-OH is you can think of it like a more potent form. It's usually chemically synthesized and it's part of what you would find in Kratom in general. Because it's not detected on drug tests, it's lots of currently causing lots of devastating relapses among Michiganders who have been otherwise stable in recovery for a long time. Michigan lawmakers, too, are currently debating the Kratom Consumer Protection Act to cap the 7-OH levels and to restrict sales to minors. So this is an unpublished study from some survey data that was sent out by California Bridge, and I bring it up just because it's so recent. This is from last month. So providers across the country reported among hundreds of patients treated for Kratom or 7-OH dependence, only 2 patients reporting requesting or preferring methadone. So this is to say that Kratom is a huge deal, but generally people's tolerance to opioids hasn't yet anyway necessitated that the people I see are needing to get onto methadone. So when you think about who is a good candidate for methadone, this is somebody with moderate or severe opioid use disorder. They have a very high tolerance. Maybe they've tried bupe in the past and it hasn't been successful, or maybe they just prefer methadone, right? The best medicine is the one you'll take. Some people who avoided OTP care in the past as well might now be interested, if you do a good job, counseling them on some of the recent changes that you just heard about. Maybe they'll reconsider. And who's to say, though, whether the specific OTP or methadone clinic that you have in mind has honored those or implemented those changes? And I think that's why it's very important to just give your local OTP a call and find out about their intake process, ask them about their take-home schedule, ask them how good or novel or fancy they are at getting people started with buprenorphine as well. Those are, I think, important things to know about your local OTP. Quick note on mobile units. These are clinics on wheels associated with OTPs that are licensed to dispense medication for opioid use disorder, and they also provide other services, and you can see some of the services that ours provide there as examples. I'm not sure the details here from this audience question, and it seems like a tragic case, but there are a couple of really great things to talk about. I'm glad this was asked, including whether medications given at an OTP are entered into a state database and what kind of consent is needed so that treatment community can continue to communicate about care safely. So the Michigan Automated Prescription System is Michigan's database for tracking controlled substance prescriptions. Remember that OTPs don't prescribe methadone. they dispense methadone. So by default, their dispensed methadone is not in a prescribed medication database. This distinction is in part due to federal privacy regulations that prohibit dispensed methadone from being listed in these programs without explicit consent. Well, that seems like a barrier to coordination. Is this a good thing? Currently, OTP dispensed medications are not universally available in MAPS, and the design inherently protects patient privacy and complies with this sort of if you could think about HIPAA, you could think of this extra sort of layer for people for their behavioral health notes or inpatient psychiatry visits or OTP visits that is called 42 CFR Part 2. So because of those regulations, things are not entered into maps. However, the absence of this data means that if an OTP can't be reached, emergency room providers, for instance, are left with a gap that negatively affects patient care if somebody were to come into the emergency room in an acute situation or further into hospitalizations or even episodes like jail stays. Can OTPs share info when we are called? Because there's no signed Part 2 release. Yes, we can and we should. Medical emergencies are one of 8 exceptions to that Part 2 privacy rule I mentioned. And when I get a call and my patient's in the emergency room, I can and should just provide the information about that. In Washington, there's actually even a rule that 24/7 our clinic has to be responsive when called. Michigan doesn't get that granular in their rules, but this policy here, policy number 5, mandates ongoing coordination between the OTP physician and other prescribing practitioners. So OTPs should be responsive when you reach out to them. It's a very important function that we play in the community to keep people's medication going when they go elsewhere. For the question about consent and communicating with other providers too, I would just say that if you maintain assigned Part 2 ROI, then yes, you should absolutely be able to require and to speak with other community prescribers for the same patient. By the way, OTPs are required to check maps before we dispense medication. So I just gave an example of, you're trying to get a hold of an OTP and you're not really, you think there's maybe a communication barrier there, and you've got a patient in the emergency room. Um, this is a very important person in every state. This is the State Opioid Treatment Authority. Every state, even Wyoming, even though they don't have an OTP, has a SOTA. And this is the official responsible for ensuring the treatment of opioid use disorder is delivered in accordance with federal and state law. So while serving as the primary sort of like regulatory liaison between OTPs and SAMHSA and DEA. So I spoke with Lisa to prepare for this talk, and she encouraged me to include her contact information. Her office can help if you have questions or run into barriers getting care for people. So thank you, Lisa. And this is me. Again, please email me. It's a pleasure to hear from everybody, and I will help you figure out whatever your question is.
So I'm going to leave that up while we go through some questions. And pull these questions up. So is there an interaction with Hep C medications, or how is methadone taken with Hep C medication?
There's generally not a significant interaction that changes the way that we provide co-treatment. Most of the time, we're using Mavorite or some pan-genotypic type of medication for hepatitis C treatment. And while it's, of course, very important to monitor things like liver function, because methadone is mostly metabolized in the liver through enzymes like 3A4 and 2C9 and 2C19 and 2D6 and all those important ones we need to think about with people taking any medication that affects their liver, it is not a barrier. So as always, all prescribing practitioners and dispensing methadone practitioners should be communicating very closely if those are 2 different people treating those 2 different things. But it hasn't been a barrier for us, especially with people who don't have cirrhosis.
And then the second part of that question is, what about HIV or TB treatments?
Same kind of thing. I think, there are lots of different kinds of HIV and TB treatments, and the prescribers will need to coordinate very closely to stay on the same page. I would actually mostly focus on that rather than getting into specific drug interactions because that's the responsibility of the prescriber for the specific medicines that they're using. So I would use the small time I have now actually just to advocate to make sure that a part two release, an ROI, is signed and to make sure the prescribers are talking with each other. But, on the TB side for treatment of latent TB, a lot of those medications can increase the metabolism, the rate of metabolism of methadone. So we see when we're treating people with latent tuberculosis that they might need an increase in their methadone dose, and that's really to be expected for all kinds of things, including pregnancy.
And you briefly stated methadone is safe in pregnancy. Someone, whoever wrote this question, was told there are potential risks for cognitive development in the infant that is born while the mother is on methadone. So they're kind of asking if that's true or not true.
I think what's important to keep in mind here is that we're always between a rock and a hard place in addiction medicine. And the decision that someone is making when they come to see me isn't should I take methadone or should I stop fentanyl? It's I can't stop fentanyl. So it's fentanyl or methadone. And I think it's important to set up like the real choice here because um, there are a lot of risks in almost every category, including cognitive, for continued drug use. And a lot of our patients are taking methamphetamine as well when they're taking fentanyl. So it's really this is the medication that is going to actually help people stop fentanyl use. Um, I think there's a lot of data out there. I'm not familiar with very high quality data that shows cognitive risks in childhood due to maternal methadone exposure. But I would just keep in mind that uh, it's usually the decision between methadone or fentanyl.
Can a PCP or pain management physician prescribe methadone for pain in an office setting?
Yes,
Okay. And what about those with pain and OUD?
that gets really tricky, right? I think that if I were a prescriber in an outpatient office and somebody had opioid use disorder, I would I would worry about whether my prescriptions for methadone are going to be, criticized as mostly for pain or mostly for opioid use disorder. I think it's not a bad idea to get a pain medication consult, a pain medicine consult, and to have a multidisciplinary approach. But yeah, that is a tricky situation. It's like certainly a case by case basis, but it is definitely allowed to be prescribed for pain. And I would say that when someone develops opioid use disorder, there's a whole host of things that you need to do when you're taking a step back and looking at what kinds of opioids I'm prescribing this person. And only one of them has to do with the legalities of continuing to prescribe methadone.
And when talking to the DEA, they said that any substance use, even THC, disqualifies patients from take homes. How can you address this to get the clients take homes that they might need?
Good. It doesn't. That's wrong. You can email me.
And
I
what?
would point out in 42 CFR and those 6 point take home criteria, the first one is the absence of active substance use disorders that increase the risk of misuse or death. And there's no evidence that THC use is increasing the risk of really any meaningfully terrible outcome. And so that single person at the DEA is, I think, mistaken in their interpretation. And there are also, the DEA is responsible for enforcing 21 CFR, and there's nothing in there about whether take homes can be given. It's a question of 42 CFR, which has to do with your accreditation for SAMHSA, and it's really about up to them to interpret. So lots of misinformation there, and the answer is definitely not. But I'm sorry that you got that answer. I know it's really hard to hear an answer like that because once you get it, you're sort of bound to say, okay, well, that's what the DEA said, and I can't ignore it, but that is incorrect.
Okay. Well, thank you again, Dr. Hutch, for a wonderful presentation and answering all these questions. We are at 1 o'clock, so we will go ahead and end the webinar here. Again, a reminder, if you didn't get the CE information off the screen, we will send an email with that information to you. And I hope everyone has a great rest of their afternoon.